Thank you very much, Mr. Chairman, for the kind introduction. Uh, and also would like to thank acadeMe for inviting me to speak in this symposium. And we are still in the session of endometrium, whereby we discuss on implantation. This is my disclosure, and this is the outline of my talk today. I'm going to talk and discuss on the different type of endometriosis classification, and then we're going to discuss on implantation in patient with endometriosis, whether it is embryo or the endometrium. And we're going to discuss and learn on how to improve the implantation and what are the strategies, and we'll conclude at the end of my talk. So everyone here knows that endometriosis is not new. It has been described 3 centuries earlier. So it's nothing new for us. And what are we now 3 centuries later? Do we have any improved understanding of endometriosis? We still debate on the origin of endometriosis. We're still not sure whether it's blamed by the retrograde menstruation, but there are growing evidence that showing that microbiome dysbiosis actually now being discussed in latest ESHRE, that it has included and become the cause of the endometriosis. And we're also not sure whether symptoms like dysmenorrhea, where we actually learn from the medical school, is the main symptoms of endometriosis. But now with the real world data, we know that it's only not dysmenorrhea, it actually also caused by menorrhagia and also lethargy. And the real world data say that the symptoms actually very difficult to notice. And nowadays, we know that the diagnosis with the recent ESHRE guideline showing that we don't need to have a surgical diagnosis of endometriosis. And the purpose of my talk today, we're going to discuss the treatment. And I know that we are all IVF clinicians here, so I'm not going to discuss about how we manage the pain and how we manage spontaneous pregnancy, but we're going to discuss on how endometriosis may affect fertility. So we're going to go for the first part of my talk, which is the endometriosis classification. So as we all know that there are many classifications here available in the world on how we actually describe endometriosis. So you can see that there's ASRM, EFI, there's an ANZIAN, there are many. And the recent review by the ESHRE HG group, and they have actually looked and they found that since 1973, can you believe that you got 22 classification of endometriosis, and none of them actually describe accurately on endometriosis. And we can see that DIE actually correlated with ANZIAN, and the EFI has been valid of its intended purposes. And there is actually the new one, the ECO, which is the disease extent, complaints, and objective that actually can give us the management. So what the review actually tell us is actually there is no international agreement on how we describe endometriosis, and actually no classification or no or very little correlation with the patient outcomes. So we know that with all the classification that we have, there are actually no correlation on the outcome. And we can divide largely classification into the severity. As you know that ASRM describe the endometriosis according to the severity. It can be minimal, can be mild, moderate, and severe. And the other description that we can use is actually the location-based, where we normally look at the peritoneum, we call it peritoneal endometriosis. We can actually look at the ovarian, where we can tell that it's an endometrioma, and it can be also impacting the bowel, and we can actually describe it as the deep inflammatory endometriosis. And the other classification that we probably will do is actually the outcome-based, which is, for example, the endometriosis fertility index, which actually can describe on how you can treat patients with endometriosis in terms of the fertility. So if we actually look at the differentiation from this Prof. Petragallia group, where they look at the different type of classification, they can see that ASRM, actually most widely used classification in the world, is actually used very easy to use, and it's simple to the patient to understand. However, the scoring system is not easy. If you can see that if SRM1 is 0 to 5 and then 5 to 25, and it's actually not standardized on the classification of ASRM. And the prognostic value is actually also not so good. So there is actually no correlation with the symptoms and the quality of life of patient with infertility. And if you go to the more recent one, ANZIAN has revised their classification, and ANZIAN actually precisely described the retroperitoneal structure, and it has been also good for the pre-op evaluation of DIE. However, it actually has no morphological characterization of the lesion, and it's very difficult to understand if you look at the ANZIAN classification. It's actually more difficult, and has poor correlation with the quality of life and infertility. And the last one that I am going to discuss is the EFI, which is very useful in developing the treatment for infertility, and it does not consider uterine abnormalities. That's the drawbacks of that classification, and it does not correlate with the pain symptoms. However, it actually very useful to predict the fertility outcome if you do know that EFI is also incorporate the ASRM in the EFI. So now we know that there are strength and limitation of each classification. Although we discussed 3 classifications here, we know that there are many more classifications in the world. So let's discuss on endometriosis and infertility. So I think everyone knows this is quite a famous diagram that we normally use. In endometriosis, it affects the tubes by the adhesions, it can affect the peritoneal microenvironment, it can affect the implantation, it affect the sperm factors, and also in ovarian endometriosis, which is endometrioma, can reduce the oocyte yield and also reduce the oocyte quality. And what happened now is patient with endometrioma, a subset of patient with endometrioma, has actually caused a stretching effect, oxidative stress, and it will reduce the ovarian reserve, causing the premature ovarian failure and then become an ovarian aging. And this is something that we already know. It's not new, all right? And we actually look at what is the effect in patients with endometriosis who are actually undergoing IVF. Do they actually reduce their outcome? So we look at 36 studies, and all the studies are retrospective. There are actually no randomized studies looking at endometriosis outcomes, and there are almost 30,000 patients included in this meta-analysis, and about 5,000 patients with endometriosis. And the control group are actually tubal factors and explained. We found that all stages of endometriosis, there is no difference in the live birth rate in all stages, however, and also not significant in endometrioma and DIE. So there is actually no difference. And you look at the clinical pregnancy rate, we found that actually in all stages, we have reduction of clinical pregnancy rate in patients with endometriosis. However, in endometrioma and DIE, we did not find any reduction of clinical pregnancy rate in women going for ART. And what strikes us most is actually the number of oocyte retrieved in patients with endometriosis, whether it's all stages or endometrioma, is significantly lower. And we look at the implantation. We present this in an Ashra, and we look at the implantation rate. Then it's about 20% lower in patients with endometriosis. We can see that the implantation is affected in patients with endometriosis. But now, the question now, whether we should blame an embryo or endometrium in patients with endometriosis. So as we all know that when implantation failure, we normally talk about endometrial receptivity, all right? However, it's not the only thing that actually involved in implantation process. So we need a good quality embryo, and also we need to have a synchronized talk between the embryo and the endometrium. So in endometriosis, because the implantation been affected 20% lower, what do you say? Is it endometrium or the embryo? So we look at the oocyte donor model, where Simon et al. In 1994 looked at the retrospective study on oocyte donor cycle, and they found that lower implantation rate if the oocyte is donated by patient with endometriosis. And when a year later, Palliser et al. Looked at prospectively on the donors in patients with endometriosis, they found that the lower pregnancy rate and implantation rate in patients with oocyte donated with endometriosis patient, and the pregnancy rate and implantation not affected in recipient in patient with endometriosis. And I think the better design study is the DS, which is the splitting the oocyte on the same donor, some actually given to the recipient with endometriosis and without endometriosis, and they found that fertility, implantation rate, miscarriage rate is not affected in recipient with endometriosis status. So we can conclude that endometriosis may related to the oocyte quality instead of giving endometrial receptivity problem. And if you look at the endometriosis and oocyte quality, we actually look at endometrioma, and we can see that there are many factors that can cause oocyte abnormalities. And we postulated that at the end, it can actually reduce the oocyte maturation and also causing fertilization and affecting the fertilization and the embryo quality. So we did an endometriosis study where we look at the follicular fluid of women with endometriosis, and we incubate the oocyte from the mouse, and we found that the maturation rate is actually affected in patients with endometriosis when they actually incubated in the follicular fluid of patients with endometriosis. So it clearly said that in patients with endometriosis, the oocyte been affected and the maturation rate is actually affected. However, when we look at the clinical study looking at the PGTA and PGTM on the endometriosis by Jenner et al. And Bishop 2021, they found that actually no different in patients with and without endometriosis on the PGTA abnormalities. So it's very difficult to say that oocyte or embryo being affected in patients with endometriosis. So for the next 10 to 15 minutes, we're going to see how we actually have a strategies to overcome the implantation defect in patients with endometriosis. So I have listed 10 strategies. So the first one, we should actually revisit the diagnosis, because sometimes even though we treat them as endometriosis, but there are actually coexisting problems. They probably have some male factors that not been treated, and they also has underlying PCOS or low ovarian reserve, and there may be a presence of endometrioma and adenomyosis in these patients. So first of all, we should look at the diagnosis, whether are we dealing only on endometriosis or there is actually a coexistent problem. And we also can do surgery in patients with endometriosis. So we did a review, and we looked at the surgical versus we are leaving the endometrioma intact in patient going for an IVF. We found that if you do a surgical treatment, there are actually a potential risk of surgical risk. You can impact the ovarian reserve, you can cause the premature ovarian failure, and also can cause a potential delay on the ART. And at the other hand, you can actually have some risk when you leave the endometrioma intact during your IVF. So if you can look here, when you are stimulating the patient with endometrioma, you probably will accelerate the progression of the disease. You probably can have a pregnancy-related complication, a follicular fluid contamination, increased requirement of GnRH and cost, and also the more important thing is the challenging oocyte retrieval, because there are endometrioma there in the ovary. So we did a meta-analysis. We actually has 3 different comparisons. So if patient with endometrioma, we compare with patient with no endometriosis at all, we noted that there is actually no difference in all outcomes, except for the cancellation rate is higher in patient with endometrioma compared to non-endometriosis. And the reviewer asked us to do, what about if you compare patient with endometrioma compared to patient with endometriosis without endometrioma? So we did the subgroup analysis. We found no difference if you have endometriosis, whether or not you have endometrioma during the stimulation. And the last one we have done is actually we compared the patient with endometrioma, whether you treat or not treated, and we found that actually no different in all outcome if you treat the endometrioma compared to endometrioma is left intact during the stimulation. So this is a bit dated. I have actually summarized this in this thing. We have actually changed endometrioma, compare endometrioma to non-endometriosis, endometrioma with no endometrioma in patients with endometriosis. We have looked at the surgical treatment, and in the review, we also look at the different type of cystectomy, and you probably can read the review. And there is an attempt to update the review. There is two updated review after my review. Is actually in 2021 and 2019. They only look at the different type of surgery in patient with endometrioma. Is only added one additional study, and it did not find any different from the findings. Okay, this is a summary of how actually surgery can cause and affect the ART outcome. And we know that if you do a surgery, you probably will have a blood vessel injury, and it causes increase the cytokines, and even though with removal of the healthy ovarian cortex, and we reduce the ovarian reserve, and it causes ovarian aging. And for completion, I actually looked at the DIE, whether we should do surgery in patients with DIE. I found that a 2021 meta-analysis looking at DIE, only 3 small studies, you can see there, and they favor the patient with surgery who actually had the ART. So in DIE, probably you can actually do surgery to improve the IVF outcome. And when I look at the ASHRA guidelines, if you can see that there's a latest update ASHRA guideline in 2022, I can summarize what are the indications of surgery in patients with endometriosis. So I divided it into indications. The indication is if you are going for the diagnostic, is there any evidence? Yes, the evidence showed that the surgical diagnosis is actually not required, and there is no superiority if you do a empirical treatment in patients with endometriosis. However, if the indication is for treatment, if the patient has a pain, yes, there is indication for surgery, but it's only for no or poor response to the medical treatment. And if it's for the treatment of fertility, the ASHRA guideline put a good practical points whereby if you are doing laparoscopy as part of the fertility investigation, you shouldn't do a diagnostic only, you should also treat the endometriosis at the same time. And if you are aiming for spontaneous pregnancy, they recommend to treat minimal and mild endo. And if you're going for ART, there's evidence, but it has to be individualized. So meaning that the surgery doesn't mean that there is no role in patient with endometriosis. There is a role, but you have to look at the indications and what you're going to aim at the end of the treatment. So we have gone to revisit the diagnosis, and then we look at whether surgery is beneficial or not in patients with endometriosis. We can now look at the medical treatment, whether medical treatment prior to the IVF can improve IVF outcome. There is a study by Bara et al. They look at they give Dynogest for 3 months, but they give like a washout for 1 month and start with the antagonist cycle, but they only include patients with 3 failed cycle, and they found that there is increased implantation rate, clinical pregnancy rate, and live birth rate in patients who actually been treated with Dynogest prior to the IVF. However, there is actually better design study by Khalifa et al. In 2021. They look at the antagonist cycle by giving Dynogest 3 menstrual cycle and down-regulated with the antagonist cycle and give the HMG. However, they found that there is no difference in implantation rate, clinical pregnancy rate, and live birth rate. So we can actually not able to decide on is there any beneficial or not. So from here, we can see that some beneficial to improve the outcome, and if you give Dynogest or progestins. However, there is actually another study giving a COCP before that. They found that the potential benefit, and there is one study that I found during my search where there is actually only a study protocol. This is not for scheduling, this is only for patients who are being pre-treated with COCP and Dynogest. So if you look at the meta-analysis done recently by Shao et al. In Journal of Ovarian Reserve, JOR, so they found that they're actually no different if you are treating patient with Dynogest, so it's probably not recommended, or is no different. It will not improve success rate if patient being treated with Dynogest. And if you look at the ASHRA guideline, there is no insufficient evidence to recommend a prolonged administration of COC or progesterone as a pre-treatment to ART to increase live birth rate. So the ASHRA also been recommended, actually no evidence that it actually can improve the live birth rate. And when we look at the ovarian stimulation on patients with endometriosis, I have tried to look at the dosing of the FSH, whether we should actually start high and come down lower, or you start at the standard protocol and increase it later. But actually there is no difference, and I don't find any evidence that being showed that there is a different dosing in patients with endometriosis. And the type of FSH, actually there is no evidence that being showed that there is actually the different FSH in patients with endometriosis. However, I found that there is a small study that showed that there is a LH supplementation, especially with long agonist cycle, where you have iatrogenically reduced the LH, where you are been giving a long protocol, so you probably will consider LH in long protocol or being given a COCP. And how about protocol? So this is a study by Giorgio. This is a latest, the most recent Cochrane review on meta-analysis, because you know Salam et al. Before in 2004, where they say that ultra-long protocol for 3 months actually improved the success rate. They found differently here, where they found that if you compare to long protocol with agonists compared to the standard protocol, there is actually no difference. It's actually detrimental if you are giving long protocol and it favors the standard protocol. However, it's only include one study, and if you look at the clinical pregnancy rate, there is no difference between the agonist and standard IVF protocol in 6 studies, and we can conclude that the clinical pregnancy rate is actually no different in patients who are being treated with agonist cycle. However, it's actually potentially detrimental for those who are actually giving an agonist protocol in patients with endometriosis. This is in contrast to what we know from Salam et al., where in 3 months protocol we thought that it will be beneficial. And a better design study, which I think been by published by Caponis et al., they have 3 different groups. A is the ultra-long protocol, and B and C with long protocol. Whether or not it's actually improved, they have made the comparison between the group A and B, A and C, and B and C. They found actually no difference between the live birth rate and clinical pregnancy rate, so that we don't actually know whether the long protocol, ultra-long protocol is actually beneficial as what we know before. So from this is the protocol, and they actually put a meta-analysis on the 7 RCTs and look at it. There is actually added one more study in 2021, and they found that ultra-long protocol could be increased, but this is not, is Journal of Gynecology and Obstetrics, which is not on Cochrane. So I think we can actually look at it. So from this data, they found that the live birth rate is actually favor the ultra-long protocol and no different in clinical pregnancy rate in patients who are going for endometriosis. However, the ASHRA recommendation said that a specific protocol of ART in women with endometriosis cannot be recommended. Both antagonist and agonist protocol can be offered based on patient and physician preference, as no evidence in pregnancy or live birth rate has been demonstrated. So we can choose whether we can go for antagonist protocol or long protocol in patients with endometriosis. So we're going to the fifth strategy, whether we should go for fresh or frozen in patient with endometriosis, because you know that patient with endometriosis, you probably will not get many eggs. And you are wondering whether you should freeze the embryos or transfer later, or you do a fresh transfer. So we found 5 studies. There are actually saying that higher number of oocyte retrieved clinical pregnancy rate in cumulative live birth rate in 3 studies, and all favors the FET cycle, although there are 2 more studies that actually no different between the protocol. And there's a meta-analysis including all the studies that I found is actually favoring the frozen embryo transfer. So in patients with endometriosis, we recommend that I think we should do a frozen embryo transfer in patients with endometriosis. And how about endometrial receptivity analysis? Should we actually offer ERA for patients with endometriosis? I found one study from Garcia Velasco looking at the endometriosis is very small study, and they found that it's no data that obtained using ERA or newly developed assays before the final conclusion to be reached on this subject. So no evidence on doing ERA for patients with endometriosis. And how about the endometrial preparation for FET? You can look at this. There is a study comparing natural cycle, HRT or GnRH pre-treatment, and Guo et al. In 2023, this year, has compared the 3 preparation, and they found no different from all different protocols. So we thought that agonist cycle is better in patients with endometriosis. However, the study showed that it's actually no different in live birth rate, clinical pregnancy rate in patients at any preparation for the FET. And the same slide that I've shown earlier, this is the PGT and PGTM, and whether you should routinely put a PGT or PGTM in patient with endometriosis, a young patient. So actually, the number of euploid embryos are the same in patients with and without endometriosis, and we thought that that is not recommended or not routinely need to be offered in patients with endometriosis. And the second last is whether we should do assisted hatching, because you know that endometriosis may have some difficult hatch embryo. I found 2 studies that look at the assisted hatching, and it's relatively small study, and it's very inconclusive whether we should offer assisted hatching in patients with endometriosis. And also from Professor Hall has talked about the immunomodulation, so whether endometriosis, although characterized by increased level of cytokine and antibodies, but they didn't actually suggest that we should give an immunomodulation in patients with endometriosis. So I think what we should do now is actually what traditionally we do. We do surgical treatment in patients with endometriosis and give medical treatment, then only ART, but I think this should be in the past. What we should recommend now, we should do a medical treatment first, make sure that the endometriosis is not getting progressed further, and we can give a pre-ART treatment before going for ART, then we can freeze the embryo and do the surgical treatment before you do the frozen embryo transfer. So in conclusion, we should revisit the diagnosis in patients with endometriosis. It has to be individualized and personalized treatment. We have to refer to the appropriate specialists that look after patients with endometriosis, and be aware on the changes of the dynamic of ART, because what I said now is probably different in 6 months later. With that, thank you very much.